A warm welcome to all of you who have dialed in from different parts of the globe to the KDIGO webinar on the 2024 ANCA Associated Vasculitis Guideline, Reading Between the Lines. Before we begin the session, I would like to review some housekeeping items. All of your headphones and cameras have been disabled for the duration of the webinar. The webinar is being recorded and is available on demand after the webinar is finished. And finally, I would request you to submit questions for the Q&A session in the chat box, and we will try to get to as many of them at the end of the session and answer the remainder offline. My name is Duvuru Geetha, and I'm a professor of clinical medicine at the Johns Hopkins University School of Medicine. I'm joined today by Dr. Brad Rovin, who served as the chair for the work group on the ANCA Associated Vasculitis Guidelines. Dr. Rovin is the Lee A. Herbert Professor of Nephrology at the Ohio State University Wexner Medical Center, where he is the Division Director for Nephrology and Medical Director for the Ohio State University Center for Clinical Research Management. The KDIGO ANCA guidelines have been recently updated to include key findings of two landmark clinical trials, the Plex trial, which tested the use of Plex, and two different glucocorticoid regimens for induction of remission, and the Advocate trial, which tested the use of Avacopan, a C5a receptor blocker, to prednisone, alongside cyclophosphamide or rituximab for induction of remission. So in today's webinar, we present two challenging cases and hope to provide guidance in the incorporation of these guidelines, updated guidelines, in the personalized management of these patients. So this slide shows a study from southern Sweden, where they looked at the incidence and prevalence of ANCA-associated vasculitis over a 23-year period. And what you see is the incidence, stratified by 3 overlapping years, which has essentially remained stable over the last 20+ years. However, the prevalence of ANCA vasculitis has steadily increased, which essentially reflects improvement in both treatment options as well as patient survival. Kidney involvement is common in ANCA vasculitis and also has implications for both complications and comorbidities. So this is data from over 1,200 patients in the DC VAC study, where the kidney involvement was common in both MPA and GPA and less common in EGPA. And what you see here is declining GFR, or impaired kidney function, is an important contributor for both complications and mortality. Patients with ANCA vasculitis experience higher mortality compared to the general population. This is a long-term data on over 800 patients enrolled in 7 different trials from the European Vasculitis Study Group, which essentially shows that compared to the background general population, ANCA vasculitis patients continue to experience excess mortality. And if you look at the factors that drive excess mortality, in addition to age, kidney dysfunction is an important contributor for the higher mortality in this population. So what are the kidney conundrums in ANCA vasculitis? What are the areas of unmet need? Number one, we are still trying to define the optimal induction therapy in those with severe kidney disease presentations. Place of Plex in ANCA-GN is still a matter of issue of debate. How to incorporate Avacopan in the induction of regimen in ANCA vasculitis is an important question. And finally, the duration of remission maintenance therapy is again an open question with no clear answers. So I'd like to start with case number 1. It's a 35-year-old Caucasian male with a history of MPO ANCA vasculitis involving skin and kidneys in 2018 and hypertension, who presents with a 2-week history of fatigue, fever, night sweats, dyspnea and exertion, and a 3-day history of cough productive of blood-tinged sputum, and declined urine output. He previously was treated with rituximab and glucocorticoids for remission induction and was given rituximab every 6 months for 3 years for remission maintenance. His medications at the time of presentation included lisinopril 20 milligrams a day. On exam, his vital signs were stable, and chest exam revealed fine crackles in his lung bases. Remainder of the exam was unremarkable. So laboratory data revealed a hemoglobin of 10.5 with a normal white count and platelet count, elevated inflammatory markers with a Z rate of 80 and a C-reactive protein of 21. Serum creatinine was 6.5 milligram per deciliter compared to 1.3 milligram 3 weeks prior to the presentation, and urine analysis revealed 1.3 grams of proteinuria and an active urine sediment. MPO ANCA titer was positive at greater than 100 units, and the remaining serologies were negative. Chest CT revealed ground glass opacities in both lower lobes. A renal biopsy was done and it demonstrated pauciimmune necrotizing and presenting glomerulonephritis with cellular crescents in 15 out of 18 glomeruli and necrosis noted in 10 glomeruli. There was mild interstitial fibrosis and tubular atrophy. So this patient has relapsing disease, MPO ANCA positive, and currently has kidney involvement and lung involvement. The kidney involvement is pretty severe, as noted by the serum creatinine, which is over 6 milligram per deciliter. Importantly, it was a very acute rise because the creatinine 3 weeks ago was 1.3 milligram per deciliter. And even more important, the kidney biopsy is very active with not much chronicity. So in this young patient with relapsing disease and severe ANCA-GN, we decided to use a combination treatment of cyclophosphamide and rituximab along with glucocorticoids, and the patient was given plasma exchange. 4 months into the remission induction therapy, his prednisone dose was tapered to 5 milligrams. He was in complete remission with MPO ANCA being negative and a serum creatinine of 1.5 milligram per deciliter. So before I go over a little bit more specific about the severe kidney disease and Plex, Brad, I just wanted to ask you if you would manage this patient any differently and your thoughts on this.
Well, I think in essence, I think I would have done pretty much the same thing that you did. I'd point out a couple of things that I was thinking about when I was going over this case. The very first thing is that this patient had MPO disease, and there's a lot of back and forth in the literature and at conferences that patients with MPO ANCA don't really relapse very much. Compared to PR3, that might be true, but they certainly do relapse, as seen here, and they can have very severe relapse. So I think the idea that MPO, when you get it in remission, is sort of a slam dunk that the patients are going to do well and do well potentially without maintenance immunosuppression is really not what or the way we practice. That's number one. Number two, if you look at, of course, the RAVE trial predominantly, and they didn't have patients or the patients weren't this severe. The idea for a relapse disease was to use rituximab because it did better than cyclophosphamide. That was particularly for PR3 patients. So our group is really a cyclophosphamide-based group, and I like the idea of using cyclophosphamide in combination with rituximab, a la the rituximab protocol, for example. And I know you're going to show some of these in a few minutes, because I think that cyclophosphamide acts a little bit more quickly in a patient like this. And finally, we're going to discuss this. I know the use of Plex, of course, remains controversial. The Pexavast trial didn't particularly answer the question definitively, but this patient seems like a perfect candidate for Plex. Rapidly progressive disease, not a lot of damage in the kidney, a lot of inflammation. So the ability to sort of control things and prevent further damage seems highly likely. So yeah, I agree with your management and would have done essentially the same thing.
Thank you, Brad. Yeah, I agree. I think RAVE trial, the biggest trial using rituximab for remission induction, excluded patients, with serum creatinine of 4 milligram per deciliter. And I think we choose this combination for a couple of reasons. Number one, I think it works fast. And number two, you end up using less cumulative doses of both cyclophosphamide and glucocorticoids. So that was the reason to have the combination therapy. Now, this subgroup of patients is really not well studied in clinical trials. So, about a quarter of the patients actually present with a GFR that is less than 15 milliliters per meter squared or require dialysis at presentation. So it's a significant number of patients. And also we know from, both from experience and observational studies, that there is no clinical or histological parameter where treatment is futile. For example, this is the study from the Chapel Hill group, which looked at 155 patients with an average presenting GFR of 7 milliliters per minute. And what they essentially showed is, even if you have a GFR less than 10 and a chronicity score of 14, there is still about more than 14% chance of treatment response. So really, it is important to study this group of patients which have not been studied well in clinical trials, because as you will see, majority of the clinical trials have an exclusion criteria as patients having a GFR less than 15 milliliters per meter squared. So here are the...
Geetha, yeah. Can I just, I think that paper and others are really important for us to keep in mind. Many of the glomerular diseases, and you know this very well, when there's a lot of histologic damage or the patients have, a very elevated creatinine and they're on dialysis, there can be consideration of not treating the patient because they're not likely to respond. A perfect example might be anti-GBM disease. But I think it's remarkable that we can salvage the kidney function. And I'm not saying it's going to be forever in these patients who've sustained damage and a lot of inflammation. But certainly keeping a person off dialysis for another few years is of benefit to the patient, their family, and of course, society. So I think this is a very important paper. I realize it's older, but I really would recommend the audience taking a look at it to help you decide on how aggressive you can be. And of course, you've got to take into consideration frailty and other issues that, might preclude severe or robust immunosuppression. But this is a really important point.
Exactly, yeah. So if you look at, either trials or observational studies which have looked at this population with severe, kidney involvement, the first trial that looked at it was MEPEX, which, obviously used a background immunosuppression of oral cyclophosphamide and oral steroids and randomized patients to either get Plex or pulse methylprednisolone. Now we use both in combination. And the second trial is rituximab trial, which, had fewer patients, but combined using rituximab with 2 doses of IV cyclophosphamide along with glucocorticoids. And the third trial is the TEXIVAS trial, which used a combination of either cyclophosphamide or rituximab along with, reduced or standard dose glucocorticoids with or without Plex. But remember, in TEXIVAS, 85% of the patients were induced with cyclophosphamide. So that leaves us with 2 important observational studies, one coming from the Imperial cohort and the second one from the MGH cohort, where they both used a combination of a short course of cyclophosphamide oral in the MGH group along with 2 grams of rituximab with glucocorticoids. And in the Imperial group, they used 3 grams of IV cyclophosphamide, 2 grams of rituximab and glucocorticoids along with Plex for remission induction. They had excellent results. Over 50% of the patients were dialysis independent at when they achieved remission. So as everyone knows, the TEXIVAS trial did not show a benefit of Plex on kidney survival at 12 months or longer. But after the Plexibas trial was completed, a previously done meta-analysis was updated, including the Plexibas patients, and this basically showed that Plex indeed had a beneficial effect with a reduction in end-stage kidney disease with a relative risk of 0.62 at 1 year. But this came at the expense of increase in the incidence of serious infections at 1 year. And based on the results of the updated meta-analysis, a clinical practice guideline update was provided, which mentioned to consider Plex in patients who had moderate to high or high risk of developing ESKD or requiring dialysis. However, when you look at the subgroup analysis, even in the meta-analysis, there was no subgroup effect based on the baseline kidney function and the 1-year kidney survival. So what I'm trying to say is, don't just look at the serum creatinine when you're determining whether a patient needs Plex or not. Look at the serum creatinine trend. And I think this is one place where I would support the requirement for a kidney biopsy. I know that some of the trials only had 40% of the patients who had kidney biopsies, whereas others had 80% of the patients with kidney biopsies. I think renal biopsy is important, really important in prognostication and assessing treatment response. And here is where, someone has a creatinine of 5, compared to what they had, like 1 milligram a week ago, but now have active disease, I would definitely Plex. But on the other hand, if this creatinine of 5 came from a creatinine of 4.5, and the biopsy showed a lot of chronicity, I don't think I would offer Plex. I think here personalization is important based on a number of factors: the level of creatinine, the trend of serum creatinine, and the kidney biopsy findings. So here is where the kidney biopsy really was evaluated. This is a retrospective observational study from the French group, looking at 425 patients. 188 received Plex and 237 did not receive Plex. And the primary outcome was end-stage kidney disease or death at 1 year. And in essence, the Plex did not have a beneficial effect either at ESRD, ESKD, or death at 1 year. However, what this study did was it was able to identify a subgroup of patients who might benefit from Plex. And these are the score points for patients without a kidney biopsy, and the highest score was given to the serum creatinine level. And if you had a score of greater than 2, then there was a beneficial effect of Plex on ESKD or death at 1 year. But if you did have a kidney biopsy, and if you had a crescentic class, it had a score of 6, now those were the patients who were benefiting from Plex. So if you had a score of greater than 7, that was the threshold, there was a benefit of Plex. 25% of the patients did not reach ESKD or die at 1 year if you offered Plex to this group with a score of 7 or greater. So I think, taking into context both the course of serum creatinine as well as the kidney biopsy findings, I think will help you make a decision on whether to offer Plex or not to these patients.
So, Geetha, let me ask a question before we go to case 2. This increased infection morbidity in the meta-analysis is something real, and of course we have to work with it. One of the things that I found surprising when we do Plex in patients like this who are otherwise overtly immunosuppressed, we like to replace with fresh frozen plasma so that we don't lose immunoglobulins and further immunosuppress them. My impression from reading that paper was that it didn't really matter what the replacement fluid was. Was that your take on it as well?
Yes, yeah. I mean, I think, ANCA-associated vasculitis patients, I think, had a different population. Even if you take other GNs, either lupus, I mean, these patients, for whatever reason, are at higher risk for infection, and higher risk for hypogammaglobulinemia. We use rituximab in other conditions, but they don't get hypogammaglobulinemic at this frequency compared to, say, lupus or other indications where we use rituximab. I think ANCA patients are certainly a different group of patients who are at really high risk for these treatment-related adverse events, which include infection.
You ever use intravenous immunoglobulin to supplement these patients?
So in patients who are hyperthermoglobulinic, with the IgG less than 300 or even less than 500 with frequent infections, yes, they get immunoglobulin. We mostly use subcutaneous immunoglobulin, and I've had good results. We don't use IV that much unless the patient has a preference.
Oh, that's interesting. I've used mostly IV. I haven't done the subcutaneous.
All right. So moving on to case 2 is a 76-year-old African American female with a history of PR3 ANCA vasculitis, previous involvement of sinuses, joints, lungs, and kidneys, who presents with a 15-pound weight loss over 3 months, nasal crusting, 2-week history of night sweats. Her previous induction therapy included cyclophosphamide oral for 6 months, and then she received azathioprine for remission maintenance for 36 months. Past medical history was notable for hypertension, diabetes, and osteoporosis. Her current medications included lisinopril, metformin, and alendronate. On examination, her blood pressure was 122/84. She was afebrile and saturating well on room air. HEENT exam was notable for crusting for both nares. Remainder of the exam was unremarkable. And laboratory data revealed a hemoglobin of 11.8 with a normal white count and platelet count, elevated C-reactive protein and sedimentation rate. Serum creatinine was elevated at 2.5 milligram per deciliter compared to 1.2 milligram 2 weeks prior to her presentation, and urine analysis revealed 1.2 grams of proteinuria and an active urine sediment. PR3 ANCA was positive at a titer of 360 units, and the remaining serologies were negative. Here again, the renal biopsy demonstrated polyimmune necrotizing and crescenting glomerulonephritis, with cellular crescents noted in 10 out of 15 glomeruli and fibrillar necrosis in 3 glomeruli. Again, mild to moderate interstitial fibrosis and tubular atrophy. So here you have a patient with PR3 ANCA vasculitis, elderly patient, previously received cyclophosphamide for induction, who is now relapsing with kidney disease and has a pretty active kidney biopsy. So we chose, and also past medical history, as you can see, her comorbidities included hypertension, diabetes, and osteoporosis. So in this patient, we chose to use rituximab because she has relapsing disease where rituximab is preferred, and PR3 ANCA serotype where rituximab is superior than cyclophosphamide. And then we gave her phosphatidylprednisone 250 milligrams IV daily for 3 days, and then gave her Avacopan 30 milligram twice a day for remission induction. And the reason we chose Avacopan is because of the pre-existing comorbidities that she has had and the prior glucocorticoid exposure. So Brad, again, I'm going to ask you, would you do anything different with this patient if you had access to Avacopan?
Yeah, so this is a great case because you can go many ways. I have no problem in an elderly person starting out with rituximab, although I still may have added a couple of doses of cyclophosphamide, but I probably would have first calculated the cumulative dose of cyclophosphamide that she received in the past, just not to exceed that. The question of Avacopan is really relevant because she does have comorbidities, and of course, a lot of the infectious complication early on is due to the glucocorticoid. So I like that idea very much. I'll throw out one other thing that may become relevant as we discuss Avacopan further, is this idea that in the Advocate trial, the patients who really benefited GFR-wise were those with severely impaired GFR. Now, I know hers isn't, but I'm getting the impression that the complement inhibitors may actually be very important for acute inflammation. Of course, we understand that, but also to decrease tubular interstitial chronic damage. And so she already has mild to moderate damage. It's not severe at this point, but she's older and you don't want her to have another flare and you want her to retain as much kidney function as possible. So I think Avacopan may provide benefit in both the inflammation realm as well as the chronic fibrosis realm. So I like the regimen very much.
Yeah, I agree. Thank you, Brad. Um, so treatment-induced damage is quite common in ANCA vasculitis, and over 60% of the patients have some kind of vasculitis-induced damage. On the right side, what you see is the number of vasculitis damage items and how it correlates with the duration of glucocorticoid use. So if you are on prednisone for over 60 or more months, 5 or more years, which used to happen, the number of VDA items exceeded 5. So there was a direct correlation with the duration of glucocorticoid use to the vasculitis damage index items. But fortunately, a number of clinical trials have been conducted, and the cumulative glucocorticoid dose has decreased over the past 2 decades, going from over 6 grams in the earlier UVAS trials to 4.3 grams in RAVE, and more recently in Advocate and LOVAS, using about 1.3 grams mean dose. So I want to share some data on what we call the glucocorticoid toxicity index. So it's an instrument which quantifies glucocorticoid toxicity, and it has 2 different components. CWS stands for the cumulative worsening score, which is a total glucocorticoid toxicity, whether it is permanent or damage or transient. And then there is something called the aggregate improvement score, which means, some patients will come into a clinical trial with prior exposure to glucocorticoids and will have some baseline glucocorticoid toxicity. So if you're trying a new investigational agent, the way that you would show that the investigational agent is helping in reducing the glucocorticoid toxicity is to show an improvement in the aggregate improvement score. So this is data from the Advocate trial, a post-hoc analysis, which showed that in 4 domains, which is the BMI, glucose intolerance, lipids, and skin toxicity, the Avacopan group did significantly better, both in terms of the cumulative worsening score and aggregate improvement score in the Advocate trial. The second thing that Brad mentioned about Avacopan is how it affects the kidney function. So this is data from the phase 2 CLEAR trial, which shows that the Avacopan group, which is the bottom group, the red and the green, had a faster decrease in both the vasculitis activity score, the urinary albumin creatinine ratio, and the MCP creatinine ratio compared to the prednisone-only group, which is the blue one on the top. So faster decrease in the urinary parameters with use of Avacopan with or without prednisone in the phase 2 trial. And this is the data from Advocate, which show that regardless of the baseline GFR, in fact, those with the severe presentation with GFR less than 20, at week 52, the Avacopan group had a greater increase from the baseline creatinine at week 52 compared to prednisone. So really excellent renal recovery with Avacopan in the Advocate trial, and more so in those that had severe kidney impairment. So the second question I have, or which I wanted to address, was in the second patient we presented with PR3 disease, relapsing disease, and kidney involvement, who we have now used rituximab and Avacopan for inducing remission. What do we do about maintenance therapy? Here we have a patient with PR3 vasculitis who is at higher risk for relapse. She has already had a relapse, so that puts her at higher risk for relapse. And she has got, impaired kidney function. So after inducing remission, creatinine did improve, but, it improved to 2. It didn't really go back to her baseline. She still has significant kidney dysfunction, which means if she were to have another relapse, the chances of ESKD remain really high. So the duration of maintenance therapy is really important, and again, this is something that needs to be personalized. So the 2024 KDIGO ANCA Vasculitis Guidelines recommend duration of maintenance therapy to be anywhere between 24 to 48 months. And here is what the trial evidence was based on. The REMAIN trial tested the use of azathioprine and prednisone, either stopping at month 24 or extending to month 48, and basically showed that patients who continued had a superior relapse-free survival. There was a 2.8-fold increase in relapse in those that withdrew from immunosuppression compared to those that continued immunosuppression. And in terms of evidence looking at rituximab for maintenance, this is a pooled analysis of the SAN 1, 2, 3 trials, which basically shows that compared to an 18-month fixed dosing of rituximab, azathioprine was inferior, the tailored dose was inferior, and the 36-month fixed dose was not statistically superior. So I think in all patients, we at least give an 18-month fixed dose interval. But I think in those that have high risk for relapse, for example, this patient, I would probably prolong it for 36 months fixed dose. I mean, she has not reached that point yet, but that's my goal. If her immunoglobulins can tolerate, I would give a fixed dose rituximab for 36 months. So again, Brad, I'm going to ask you how you would address maintenance therapy in this patient with PR3 ANCA disease, relapsing disease, and impaired kidney dysfunction.
Absolutely agree with you. I think that in most of my patients, we get referred, as you do, patients who are fairly severe, and they don't really have room for additional relapses, knocking out more and more kidney parenchyma. And so I tend to leave patients on maintenance immunosuppression for a very long time, generally at least 3 years. And I realize and agree with you, it should be an individualized decision. But I like using rituximab. What I find is that if you do the fixed dose, which is what we have traditionally done, I check immunoglobulins to see that they're okay, as you mentioned. I also check B cells, because sometimes the fixed dose doesn't have to be 1 gram or 2 grams at 6 months. The more and more you treat patients with rituximab, the less and less you need. And sometimes it doesn't have to be every 6 months. You can get away with a little bit longer in between. Patients seem to really like it because they're not taking pills every day, and they're very adherent to that regimen. So absolutely agree. In this particular case, you don't want this older person to relapse again, because it's going to take out more and more of her kidney.
Right. I agree. I think the tailored dose, even though trials showed that there was no superiority or compared to the fixed dose, we continue to use that, and we really used a lot of it during the pandemic, and patients did well, because that was an opportunity to use less rituximab. So we used a lot of tailored dose rituximab during pandemic and didn't really have any problems with the tailored dose. I think we use it.
It's remarkable that we didn't have more trouble with it during the pandemic, but that's good.
So I think we are going to stop here, and let me look at the chat and see what questions we have. Okay, the last question I'm going to read. For a patient with PR3 ANCA vasculitis and hypogammaglobulinemia getting IVIG now, have you considered transitioning after 36 months of rituximab to another year of azathioprine or even more? I have, and in fact, I actually have a patient now. She's not PR3 but MPO ANCA positive with frequent renal relapses, who is on IV immunoglobulin for hypogam, and she's on azathioprine along with that. So yes, certainly it's a consideration. I think if you cannot use rituximab, azathioprine still works. Again, mycophenolate works if somebody doesn't tolerate. So those are two options when you have patients with kidney disease.
Remember, before the azathioprine comparison to the mycophenolate, we were mostly using mycophenolate for maintenance therapy in our patients, and in general, they were doing very well. So I think there's lots of options for maintenance therapy.
The next question I have, when using combination of cyclophosphamide and rituximab, do you follow rituximab's protocol or the MGH group that mostly uses oral cytoxan? I mean, personally, I also use oral cytoxan, so I follow the MGH protocol. In fact, I use a different type. I start patients with oral cyclophosphamide, and they're generally on it for anywhere from 4 to 6 weeks. And at either week 4 or week 6, I stop the oral cyclophosphamide and give them an induction course of rituximab. So I use it sequentially rather than simultaneously, but I use oral cyclophosphamide.
We use oral we were a very proactive oral cyclophosphamide group, but my younger faculty are pushing me more towards intravenous cyclophosphamide these days. So we follow the rituximab protocol as opposed to what Geetha was just describing, but I think either one is fine.
The other question, why nephrologists are afraid to use cyclophosphamide?
Yes, I just saw that question. I don't think that's true.
I'm not sure whether nephrologists are afraid or rheumatologists are afraid, because I think we use a lot of cyclophosphamide compared to, rheumatology. So I'm not sure that I agree with that question.
No, I think everything should be taken into perspective, right? The idea of a healthy respect for cyclophosphamide is really important. You need to think about what you're doing. And nephrologists are not afraid of cyclophosphamide, but we do know that cyclophosphamide can be retained in patients with, renal insufficiency or impaired GFR. So we want to dose the cyclophosphamide appropriately for the given patient based on their kidney function and also based on, their infection risks, et cetera. I think everyone's goal would be to get as far away from cytotoxic drugs as possible if that's reasonable for patient care. And that's why it's nice to have options. And certainly in the lupus field, you've seen a very far remove phosphamide for induction therapy in lupus these days. And patients are well educated, right? They look on the internet, and if they see there's options and you read the side effect list of cyclophosphamide, it can be pretty scary. So I think we don't hesitate to use it when it's appropriate. And I think we've illustrated several examples where we would use it in real life.
Would the degree of fibrosis sway you away from not treating with rituximab or cyclophosphamide greater than 60%? I think that's why I put the Chapel Hill data. I think if you have active disease, it's ANCA GN is focal. So if you have active disease, you have to treat them no matter what the degree of fibrosis is, because even in dialysis-dependent patients, if you use the optimal induction therapy, you're able to get 50% or over of the patients off dialysis. So I think it's important to treat these patients if they can tolerate.
I agree. We almost never give up on an ANCA vasculitis patient without a good try at immunosuppression. This question really begs the question of our discussion of the complement inhibitor and its potential role in not only helping control inflammation, but maybe in preventing fibrosis. And we'd have to know more details about the patient, but this might be a place where Avacopan could shine and benefit the patient. This is all theoretical now, but I think more and more data from more and more diseases are suggesting the complement inhibitors may have an effect on chronicity as well as activity. So this is very relevant to think about going forward with these new drugs that are really appearing every day.
Right. The next question is PR3 ANCA, MPO ANCA to test and make big changes. I don't use ANCA to make any treatment changes, but I think there are a few places where I think it is helpful. If I certainly follow ANCA titers, in the beginning, and then when I think someone is in clinical remission, I check an ANCA, because if you're ANCA negative when you're in clinical remission, the relapse risk is low. And then the second place where I've been using ANCA is when I check immunoglobulins, when I check CD19, I also check ANCA titers, especially if they've been ANCA negative. And, they've already had 3 years of rituximab, but they're still at risk for relapse. And I use a combination sometimes of CD19 and ANCA to decide whether I need to redose them or not. So during the follow-up, I would use, but not, I won't make any treatment changes just based on the ANCA alone.
But if you saw changes in the ANCA, you would follow that patient more closely for a relapse, right? If they were doing well and the ANCA became positive again, something like that.
Yes. And then the second question, when to start Avacopan and for how long, and steroid with it. When to start Avacopan, I think as soon as the diagnosis is established is the best time to start, because we did do a real world experience study which was published in KI reports, where we basically showed that the earlier that you start Avacopan, you will have the benefit of lowering your cumulative glucocorticoid dose. If your aim is to lower the cumulative glucocorticoid dose, you have to start it early. So you start it as soon as you can, because I know early on we had trouble getting Avacopan. I don't think it's a problem anymore, so you should start it on day 1 if you can. And how long do you use the steroids? I mean, as I mentioned in the patient, I did use pulse methylprednisolone, 250 milligram daily for 3 days. But the oral prednisone, I do use it, but taper it off really fast over 3 weeks. In the Advocate trial, patients came into the trial with a median dose of 20 milligram, but they were off prednisone by week 4. Now, I get them off prednisone by week 3. People differ, but, so that's how I have done. And how long to continue Avacopan in general? For 52 weeks, because that is what the trial did. But I've had a few exceptional cases where I've actually extended the duration of Avacopan because I could not use rituximab, either because the patient had low IgG or the patient could not get rituximab. So those are the instances where I've extended the duration of Avacopan treatment.
Do you see this? There's a question here that I think we should just comment on, Geetha. It's suggesting, can we only use rituximab or any B-cell depletion therapy for the disease?
Oh, okay. I think what has been studied in trials is the rituximab, but what is being currently studied is the humanized version, the obinutuzumab. We have one trial in the US and another one in the UK going on now. And the rationale for using obinutuzumab is, better B-cell tissue B-cell depletion. Just like I think you're going to find, just like in lupus, that obinutuzumab is probably going to work better for ANCA patients compared to rituximab.
Yeah, the things that I like about obinutuzumab, and of course, we're way off label here right now. The drug has not been approved for any of our autoimmune diseases yet, but as Geetha said, it's being trialed in lupus and other autoimmune diseases that we're concerned about. The tissue penetration is supposed to be better, and I do think it's important to get inside the kidney and clean up any B cells there for the possibility of renal-specific autoimmunity. The other thing that I think is really relevant for obinutuzumab is the rapidity with which B cells are depleted. Within days of the first dose of a 2-dose regimen over 2 weeks, the B cells are over 90% of the patients have complete B cell depletion. This is far better than rituximab, at least in the lupus population. And I know the populations may be different because rituximab needs complement for cytotoxicity, and lupus patients are complement depleted. But the point is that what I'm looking forward to with rituximab is, if it works this quickly, would this be something we could use in very severe disease where we want a rapid onset of action, and then not being afraid of cyclophosphamide, but not have to use cyclophosphamide, maybe just use obinutuzumab. Theoretical at best, right? Because this is remains to be seen, but something to think about.
Yeah, well, that would be great. Like if you can avoid cyclophosphamide, if obinutuzumab, causes a much more rapid B cell depletion, that would be really important. Okay.
So I think, Geetha, we're at the end of our seminar.
Yeah, so I like to acknowledge that this webinar was supported by Amgen, and I thank everybody for your attention.
It's been a pleasure to be here and do this webinar with you. I think it was a lot of fun. Thanks so much.
Thank you.